Contraception resources from the CDC, 2016 United States Medical Eligibility Criteria for Contraceptive Use, a webinar from the Division of Reproductive Health at the Centers for Disease Control and Prevention. The findings and conclusions in this report are those of the author and do not necessarily represent the official position of the Centers for Disease Control and Prevention. This presentation will review the U.S. Medical Eligibility Criteria for Contraceptive Use, the intended use and target audience for these guidelines, and strategies that you can use to incorporate CDC contraceptive guidelines into everyday practice to improve the quality of family planning care. The U.S. Medical Eligibility Criteria, or MEC, is an evidence-based source of clinical guidance for the safe use of contraceptive methods by women and men with various characteristics and medical conditions. It is intended to assist healthcare providers when they counsel women, men, and couples about contraceptive method choice. The U.S. MEC includes over 1,800 recommendations for more than 120 conditions and characteristics, and also includes information on certain drug interactions. The U.S. Medical Eligibility Criteria and Selected Practice Recommendations for Contraceptive Use are companion documents. Both were adapted from the World Health Organization for the United States context. The CDC and WHO use an automated system to continuously monitor newly published evidence on relevant contraception topics. Topics with new evidence that was inconsistent with current recommendations were selected for guideline updates at a meeting of subject matter experts in 2014. In addition, new topics were also considered. Over the next year, CDC and outside staff conducted systematic reviews of the evidence for these topics. These reviews were presented and discussed at a second meeting of national experts on family planning and reproductive health in 2015, with subject matter experts present for discussion of each medical condition. The CDC then finalized recommendations for the 2016 updates. Prior to the development of the World Health Organization and the Centers for Disease Control and Prevention guidelines, most contraceptive guides around the world were based on medical textbooks or on the individual clinical practice of the author. They also generally address contraceptive use for healthy women, with the result that in many places around the world, including the United States, women with medical conditions were denied access to contraceptive methods. CDC and WHO wanted to develop guidelines that were based on the best available evidence, that would address misconceptions regarding who can safely use contraception, and remove unnecessary medical barriers, thereby improving access and quality of care in family planning. Both documents have been endorsed by the American College of Obstetricians and Gynecologists and the North American Society for Pediatric and Adolescent Gynecology. We will now look at the U.S. MEC in more detail and apply the guidance to clinical scenarios. The U.S. MEC contains recommendations regarding the full range of contraceptive methods listed here. Intrauterine devices, including copper and levonorgestrel IUDs, progestin-only contraceptives, which include progestin-only pills, depo-medroxyprogesterone acetate injections, and etonogestrel implants. Combined hormonal contraceptives, which can contain estrogen and a progestin, and include combined pills, patch, and ring. Emergency contraceptive pills, which include levonorgestrel, ulipristal acetate, and combined oral contraceptive pills. Barrier contraceptive methods, which include male and female condoms, spermicides, diaphragm with spermicide, and cervical caps. fertility awareness-based methods, which include symptom-based and calendar-based methods, and also lactational amenorrhea, withdrawal, and sterilization. Within the MEC, recommendations for use of contraceptive methods are based on specific pre-existing medical conditions or individual characteristics. Recommendations refer to methods being used for contraception, not for the treatment of a medical condition, which may change the risk-benefit analysis. This chart depicts the effectiveness of contraceptive methods. The US MEC and SPR are organized according to contraceptive effectiveness. The most effective methods are listed on the top row. Less than 1 out of 100 women using these top row methods will become pregnant over 1 year. The methods in this row include reversible methods in yellow, such as the implant and intrauterine devices, as well as permanent methods in blue, such as female and male sterilization. The middle row shows moderately effective methods, in which 6 to 12 women out of 100 will become pregnant with 1 year of these contraceptive methods use. All of these methods are reversible and include injectable contraception, combined hormonal contraception, including the pill, patch, and ring, and the diaphragm, which is a barrier method. The bottom row shows the least effective methods. 18 to 20 women out of 100 using these methods can expect to become pregnant over 1 year. These methods are also all reversible and include the male and female condoms, withdrawal, the sponge, fertility awareness-based methods, and spermicide. Please note that condoms should always be used to reduce the risk of sexually transmitted diseases. Within the medical eligibility criteria, each combination of a medical condition with a contraceptive method has a recommendation for use, which is provided as a numeric classification, 1, 2, 3, or 4. The numbers reflect an increasing degree of theoretical or proven risks for use of a particular contraceptive method for a woman with a particular condition. Category 1 classifications indicate no restriction for use, while Category 4 classifications represent unacceptable health risks. A number 2 means that most evidence suggests that it is generally safe for someone with the particular condition to use a particular method, and that the advantages of using the method generally outweigh the theoretical or proven risks.